we normally measure it with measurements of the left ventricle. It's very difficult to talk about the mitral valve without talking about the left ventricle. So what I'm going to be doing today is just presenting an interpretation of the evidence and probably how it can apply to some clinical scenarios. I do have a conflict of interest in that I'm a director of Sydney Heart Valve, which has a couple of patents on heart valves. It's a nice day today. I rode my push bike here, but also Sydney Heart Valve is a very expensive hobby. Firstly, the principles. There is no treatment in medicine that does not have a risk or a side effect. So we trade in evils, essentially. And if the evil of the disease exceeds the evil of the treatment, that's a good trade. In mitral surgery, everything we do to the mitral valve represents a real and measurable evil. We have to be very careful about the way we trade in mitral valve surgery. The heart is a pump, and we do need to know physics. The physics of the left ventricular pump can be complex, but just for today, we only need to know about Newton. If the papillary muscles are pulling on the mitral valve is pulling on the papillary muscles. If the left ventricle is pumping blood in one direction, the blood is pushing the heart in the opposite direction. Sorry, one slide too many. Page up, thanks. Okay, so just very briefly about anatomy and mainly for the purpose of terminology. On the left, we have the mitral valve, which is named, partitioned as A1, A2, A3 for the anterior leaflet, P1, P2, P3 for the posterior leaflet. The anterolateral papillary muscle supplies A1 and P1 and part of A2, P2. Posteromedial supplies A3, P3 and part of A2, P2. No chordae across the midline. On the right-hand side, we can see the anterior leaflet has no muscle border. And for the terminology of the chordae, the marginal or primary chordae attached to the free edge of the leaflets. There are basal chordae, which to the posterior leaflet are equally dispersed around the posterior annulus and probably contribute to annular dynamics. The basal chordae to the anterior leaflet are known as strut chordae, and they're the strongest, thickest chordae in the heart. So the left ventricle is the cone shape of the left ventricle is the universal design of the systemic vascular pump in the mammalian world. It's like the piston engine is the universal engine for a fossil-fueled car. The ventricles evolved over millions of years, and we have to assume that everything has a purpose. The blood flows into the ventricle through the mitral valve, around the apex and out again through the aortic valve. Sorry, I'm face down. And of particular note, the anterior leaflet is part of the aortomitral curtain. It separates the inflow part of the ventricle from the outflow part of the ventricle. It can be dislodged under the aortic valve and cause outflow tract obstruction. Now, this is the focus of our research at Charles Perkins Centre here at Sydney University. We need to talk about the Newtonian mechanics, and they're the forces directly through the papillary muscles, annular dynamics, flow dynamics, and left ventricular cocking and torsion. If we put in a prosthetic mitral valve, we normally take out the anterior leaflet. When we do that, we abolish quite a substantial portion of the forces applied directly through the papillary muscles. We immobilize the annulus. Taking out the anterior leaflet affects the transmitral flow dynamics, which improve the efficiency of the heart. And we also know that it interferes with the cocking and torsion of the ventricle. So let's just have a look at the ventricle. We've known for 30 years that the distance between the papillary muscle tips and the plane of the mitral valve remains constant throughout the cardiac cycle. However, the long axis of the left ventricle does shorten, and this shortening occurs between the apex and the tips of the papillary muscles. So the dominant forces, functional contractile forces at the base of the heart are radial, and in the low volume apex chamber, they're longitudinal. So we can actually think of the left ventricle as a two-chamber phenomenon where the base of the heart is the volume chamber and the apex is like a piston pumping the blood up towards the aortic valve. So let's look at the importance of preserving the anterior leaflet for the purpose of left ventricular function. As I said, if the ventricle pumps blood in one direction, there's a force on the apex in the opposite direction. So I've mentioned the jet-propelled racing car theory before. The difference between the ventricle and the racing car is that the racing car has a rigid chassis. The ventricle can stretch. It needs a rigid chassis. It does actually have a rigid chassis in the form of the strut chordae to the anterior leaflet. These remain constant throughout the cardiac cycle. We know that cutting the strut chordae results in extension of the long axis of the left ventricle. The strut chordae are in line with the vector of left ventricular ejection, and therefore they brace the ventricle against the acceleration of blood out of the ventricle. There are other chordae, of course, the marginal chordae and the posterior basal chordae I've mentioned. For the marginal chordae, the majority of forces, the total force exerted through the marginal chordae exceeds that through the strut chordae. So interfering with the marginal chordae will cause the greatest loss of the mechanical forces supporting the ventricle. So the marginal chordae forces are derived from the force of intraventricular pressure on the area of the closed mitral valve. In our animal lab, we split the anterior leaflet in an ovine model in a normal heart, normal beating heart, and we found quite dramatic changes in hemodynamics and contractility. The stroke work decreased by 23%, stroke volume by 12%, cardiac output went down by 9%, heart rate went up a little bit, but not much. the left ventricular end systolic pressure went down. Left ventricular end diastolic pressure went up. So obviously the heart's getting quite sick. We only got contractility measurements, the ESPVR and the PRSW, on 3 sheep. So I don't think they're statistically significant. But the point about the pressures exerted through the marginal chordae is like the wind pushing a yacht through the ocean. If we put a split all the way through the spinnaker, the boat would just slow down quite dramatically. And so this is what happens if we split the anterior leaflet of the mitral valve. However, when the leaflet, as we normally think, the papillary muscles pull on the leaflet, but as Newton says, that means the leaflets are pulling on the papillary muscles. So the papillary muscles are intermediary. The forces are actually exerted through the left ventricular wall, through the apex, and this is the piston effect of the apex. Now we can think of the effect of this in a 4-cylinder motor car, where we knock out one of the cylinders in the motor car will slow down. But what we can do then is just push on the accelerator a bit more, we regain the power, and it's all okay. And the heart does that, and the heart regains power. That's called adaptation. But adaptation is purchased at the expense of reserve. So we're never ever going to regain top speed if we only have 3 cylinders. So on to flow dynamics. This is a very old couple of MRIs. On the left, we have a normal mitral valve, and you can see the anterior leaflet is opening and directing the inflow around the posterior wall of the left ventricle. The flow remains constant throughout diastole, so that at the end of the diastole, you've still got forward flow approaching the aortic valve. The ventricle simply accelerates that continuous flow out through the aortic valve. On the right-hand side, we have a patient who's got a mechanical valve in, and the anterior leaflet has been excised. The blood flows through the mechanical valve into the ventricle and simply floods the ventricle. There's turbulent flow, and the ventricle needs more work to re-establish outflow. So the laminar flow is generated by the anterior leaflet. The anterior leaflet opens as a half tunnel, and this is created by the strut chordae on A2 on A3, A1, A3, which remain constant throughout diastole and limit the excursion of the sides of the anterior leaflet. And this might go might explain why mitral annular calcification circumferentially at the base of the anterior leaflet will cause mitral stenosis. But the extension of aortic calcification as a ridge down the top of the anterior leaflet does not appear to cause mitral stenosis. There's a cartoon illustration of the same thing that we saw on the MRI. Blood flows in through the mitral valve, hitting the posterior wall, out through up to the aortic valve again. But this cartoon also shows the effect on the anterior leaflet of the mitral valve, where the vortex, as it approaches the outflow through the aortic valve, actually assists in anterior leaflet closure. And this may be important in HOCM, where the flow pattern through the left ventricle is disturbed. We normally think that the systolic anterior motion that contributes to outflow tract obstruction in HOCM patients is due to a Venturi effect. But it is very likely that it's a combination of the altered vortex that assists in closing the anterior leaflet and the Venturi effect of accelerated blood flow out through the outflow tract that causes the late systolic anterior motion in HOCM. The image did not work. Good point. Still not working. This actually is a movie showing annular dynamics. Without looking at the image, the posterior annulus is quite dynamic. It moves in two directions. Firstly, it acts as a constriction of the mitral valve throughout systole, and it also moves down towards the apex in systole. So in diastole, it will open up and it will move towards the left atrium. And the importance of this is that two things happen. The constriction of the annulus improves mitral valve function, but also the diastolic relaxation assists in left ventricular filling. The left atrium is the only extra-pericardial structure of the heart, so it's fixed. All other parts of the heart are free to move within the pericardium. So when the annulus dilates and moves towards the left atrium, it's a momentum effect. It's almost like the annulus is the mouth of a big barramundi fish, which comes and goes woof to a large portion of the left atrium and just swallows it up. And that's a form of assisted diastolic filling of the ventricle or mechanical lusotropy, whatever we like to call it. So both the systolic component of annular dynamics and the diastolic component of annular dynamics support left ventricular function. So why do we resect the anterior leaflet when we put in a mitral valve prosthesis? As I say, it is trading evils at the ultimate extreme. If we use a bioprosthesis, we are at risk of getting left ventricular outflow tract obstruction. The bioprosthesis will immobilize the anterior leaflet and move it towards the left ventricular outflow tract. If the anterior leaflet is dragged into the outflow tract following a surgical implanted bioprosthesis, it tends to be a lethal condition. If we put a mechanical valve, we actually can retain the anterior leaflet quite safely, and particularly if it's in ischemic MR. Because in ischemic MR, the valve is tethered within the ventricle. There's no risk of caudal rupture, so there's no risk of prosthetic leaflet entrapment. Unfortunately, people don't retain the anterior leaflet when they put in a mechanical valve, but it should be done if it was performed for patients with ischemic MR. Unfortunately, their 5-year survival rate is not such that we would be inclined to put a mechanical valve in, so it just doesn't happen. If we are going to chop out the anterior leaflet, then just how much should we chop out? The current standard of care is just to chuck the whole lot in the rubbish bin from the outset and get on with putting the valve in. Tyrone David, some 30 years ago, suggested that we could get away with less than that, which would be logical, because although taking out A2 will remove the forces through the papillary muscles that are applied from the marginal chordae, it will retain the strut chordae, and we know the strut chordae are important. So that would be the logical recommendation. Historically, we've always plicated the posterior leaflet, but that should only be done if it has the risk of leaflet entrapment of a mechanical valve. The marginal chordae from the posterior leaflet will provide sufficient force to make a noticeable difference to left ventricular function. So what about repairing ischemic MR? On the here's the posterior leaflet, here's the anterior leaflet. The anterior leaflet is bowed up a little bit, and this is the transmitral plane. So this is what we call the tethering area. We should have the leaflets coapting much closer to the transmitral plane. The mitral valve has been dragged into the leaflet by left ventricular dilatation as the pupillary muscles have moved away from the mitral annulus. And particularly the doming of the anterior leaflet is caused by the excessive tethering by the strut chordae. So people have divided the strut chordae, they've improved leaflet coaptation and improved the repair rate in these ischemic MR patients. But we know the strut chordae are important. So logically, rather than just chopping it off, we could detach it and then reattach it to the trigone. But knowing what we do know about the importance of the strut chordae, it would be simply better to put in a new chordae between the pupillary muscles and the trigone. That'll do me very nicely. Thank you very much.